Good morning. I'm Andy Mayo. I'm the president and CEO of Medical Benevolence Foundation, located right here in Houston. And this morning we're going to talk about something interesting. I'd like to start off with a story. Several years ago when I started at MBF, one of the very first things that happened to me is I had the opportunity to meet a woman by the name of Hilda Alcindor. Hilda is a nurse. She was born in Haiti, got her nursing degree in Haiti, but came to the United States and worked as a U.S. Army nurse for about 20 years. And after she retired from the Army, she moved back to, they recruited her and she moved back to Haiti and started the FSIL nursing school in Leogane, Haiti. At that time, it was the only baccalaureate program for nurses in Haiti. And turns out, in our opinion, some of the very best nurses. But Hilda is a force. She has made that school happen, and it continues today many times through her sheer force of will. And I can still remember she was sitting across my desk, and she was shaking her finger at me. And she said, "No more fish." And I said, "Hilda, what do you mean?" She says, "No more fish." And I said, "I still don't get what you mean." She said, "Don't bring us any more fish. Teach us how to fish." So with that sort of story, we're going to talk today about an inflection point, a major change that's happening, a tipping point for mission hospitals around the world. And the question is, do we even notice that it's going on? And what can we do about it? Does anybody even care? My bold prediction is by 2040, the mission hospitals as we know them, the legacy mission hospitals as we know them, will not exist as they exist today. Some of them may not even be in business, and the majority of them will have lost their mission of proclaiming the gospel if we do nothing. So, I want to start with 3 principles, and then we're going to talk about the situation. So our 3 principles, the first of our 3 principles, come from industry here in the United States. Over the last 40, 50 years, major companies here in the United States have spent millions and millions and probably billions of dollars in quality improvement and working on processes for improving the quality of products and services here in the United States. Even within our hospitals, this has gone on. And one of the major principles from quality training and quality systems is that systems trump training. That principle simply is that no amount of training on an individual, no amount of training you can do for that person, if you take them and put them in a system that is broken or doesn't function properly, the system will end up trumping the training that person has received. Let me give you an example. We were recently in a hospital in Kenya. We were up on the 2nd floor of the hospital, and the gentleman that was with me was looking around, and he noticed there is no running water anywhere on this unit. Nowhere on the 2nd floor was there running water. And they said to the nurse, "Well, what happens? You're not washing your hands between patients." And she said, "Well, that's okay. I use latex gloves." "Oh, really?" She said, "Yes, I put a pair on at the beginning of the shift, and I use those during my shift, and I take them off at the end." No amount of training for that nurse was going to change her because the system of the hospital did not allow that to function properly. I have my own corollary to this, and that is systems trump projects. That simply is no amount of great projects that we're going to do. We can't take a project that's going to fix something, take it to another country, and implement it, and have that work. Even the USAID got this right from their website. They say high-impact interventions can only be sustained at scale if they are integrated into existing health systems, structures, and processes. Meaning, if you don't take this great new idea you have and integrate it into an existing system, it's not going to work. Even Melinda Gates, in a recent interview with The Economist magazine, said, we have spent billions on vaccines, on new treatments, but they will not be effective because in many places they won't be or can't be, don't have the personnel to be implemented. So if the local culture doesn't allow it, doesn't adopt it, it won't matter how much you spent on developing it, it's not going to happen. Our third principle that we want to sort of filter our discussion through is what I call translation happens through relationship. What does that mean? Think of a Wycliffe Bible translator. What do? They go and live with the people, understand the culture in the process of translating the Bible. Have you used Google Translate, taken something that is written and run it through Google Translate and read what comes out? Google Translate's great, but it's far from perfect. There's a lot of culture, a lot of meaning, a lot of sense that goes into translating something. So those three principles, systems trump training, systems trump project, and translation happens through relationship. So now, I've always been taught that a good presentation is what, so what, and now what. So we're going to talk about three different things today. We're going to talk about how are legacy mission hospitals challenged. In other words, what are their limitations to change? Then we're going to talk about that inflection point, that change point that's going to happen to them between now and 2030, 2040. And then we're going to talk about what needs to change for those hospitals. What are they going to need to do to get better and to survive? So the what? What is the sustainability challenge for a mission hospital? What do those look like? If we got on a plane and went to virtually any developing country today, walked into what I call a legacy mission hospital, we would tend to see the same things, relatively consistency throughout the world. What we would see is there's often a lack of professional management skills. We see a board of directors. The board of directors of many mission hospitals are local pastors, many of those local pastors with no better than a high school education that have been brought together to supervise and manage or supervise and oversee the hospital. We see managers in place that may at best have a college education, but certainly don't have a professional degree in hospital management. So you have a complex organization, high number of employees, highly structured, with leadership that has not been trained for that position. At the same time, what we're seeing in the last 10 years is that many long-term missionary doctors, physicians that have been there long-term, have left or are leaving the field. So this trained physician from a Western country who has been serving there for a long period of time is left, leaving them there on their own. And many times the mission agency that supported the hospital has left with them. So now you have this local mission hospital sitting and trying to make it on its own. What's happening at the same time in their local market is a huge increase in competition. The governments are increasingly building government hospitals, and in many countries, as a level of higher earning or middle income population grows, physicians or other organizations will start hospitals for the paying patients. So here are the mission hospitals of the world left, competing with everybody that's out there, serving only the patients that can't pay. More and more, they're being left what's sort of the leftovers. If you can't afford anything, go to that Christian organization over there, and maybe they'll take care of you. At the same time, most of these hospitals have declining facilities. We work with one hospital that was the original hospital built in Kenya over 100 years ago. Most of the hospitals that we work with in these developing countries, facilities were built as mission hospitals in the 50s or the 60s. So they were a nice little mission hospital back in the 60s, but now they're not so great anymore, and they're at a point of declining facilities at the time all these other things are happening. And at the same time, as we know here, technology is changing rapidly so that every new step, every new service you implement comes with not just, excuse me, I'm getting over a cold, not just more equipment, but more expensive, high tech, very expensive. So you now have digital x-ray. Oh, you want to go to the next step? You're talking about an MRI. Oh my gosh. Or a cath lab, or any number of things that are, it's sort of an arms race within the healthcare industry. So it's not easy. These are all the limitations they're faced with at a time when things are changing rapidly. So what is the inflection point that's happening for them? What hospitals in developing countries are going to see is much like the healthcare system experienced in the United States between the 60s and 2000s. So you go, okay, maybe you weren't around to experience that, but unfortunately, I hate to admit it, but I was. So let's look at a few of the facts. In 1965, this thing called Medicare and Medicaid was introduced in the United States. So in 1964, there was $0 spent by the U.S. government on health care. Today, anybody know what the budget for Medicare and Medicaid is? $1.19 trillion. The government spends 24% of the government budget just on Medicare and Medicaid. Big change. 1973 was the creation of this thing called an HMO, managed care. So that's in terms of the big changes just on financing. Went from government spending. Now we've introduced Medicare. On the clinical side, until the 60s, we had segregation in our hospitals. So we segregated people by sex and by race. We had different wards for different people. That was the 60s. In 1982, we introduced this thing called the DRG, which was a classification of diseases, and introduced external clinical evaluation. So what began happening on the clinical side was we went from a system where a doctor was in charge and he did everything. So now we've got HMOs, we've got this DRGs. People are beginning to evaluate. We're changing from a doctor-centric, paternalistic model to what we have today, which is patient-centric, patient-empowered, but external forces, somebody at your insurance company or your health maintenance organization is looking over the shoulder of the doctor, deciding whether he's practicing the right way. We've had a significant, on the clinical side, significant increase in the education and role of nurses. In 1966, 16% of the nurses had a bachelor's degree. Today, 60% of nurses have a bachelor's degree, and by 2020, they think it will be 80% of nurses have a bachelor's degree. What's the significance of that? We've moved from a very task-oriented clinical care to now one that is critical thinking, where we expect our health workers to be focused on the outcome, not just the task they've been assigned to do. And with that has come an increased reliance or increased focus on valid research and evidence-based practices in the clinical care. The third area of change that happened in that period of time was administration. And I go, okay, what's the difference? Well, between 1975 and 2015, we had a 22% decrease in the number of hospitals in the United States. And today, about 65% of them are part of a healthcare system. So we went from having your local community hospital through a consolidation process to now these hospitals are having to be in a larger healthcare system to exist. Probably the most frightening point of all of that is in that period, the church has essentially divested itself of its healthcare ministry. We went from the 1960s, you think of even here in Houston, where you might have had a Catholic hospital, a Baptist hospital, a Methodist hospital, a Presbyterian hospital, to a point today that the churches no longer are involved, and maybe their name still remains part of the name, but the church is not involved. They don't see hospitals as a ministry of the church any longer. The church has gotten out of the business of the United States of medical care as a method to share the gospel. So what? Legacy hospitals legacy mission hospitals are going to have to change. They are not going to have any choice. So what do they have to change? They're going to have to implement clinical standards. They're going to have to both from a perspective of clinical standards on the units. So you think of, in the United States, you might think of the Joint Commission on Healthcare Accreditation. Other standards in the way they do things. They need to improve their systems, both IT and clinical. And they need to change the clinical care process, evidence-based standards. For example, one very simple one that is widespread in all our hospitals today is the 7 rights of drug administration. So there's 7 steps that they go through to verify that you have the right patient, the right drug, all of those things in terms of the administration of a drug. Legacy mission hospitals are going to have to change the management and their governance systems. They need a vast upgrade in both the staff that is managing those organizations as well as their board of directors. And most of all, what we see is many of these legacy mission hospitals need to re-energize their spiritual programs. So what? Now what? What do we do? What can you and I do? First thing we do is pray. What is it? Philippians 4:6. Wrote from the Living Version. I wrote it down because I really like this version. Don't worry about anything. Instead, pray about everything. Tell God your needs, and don't forget to thank Him for His answers. I got news for you. We got to start with prayer. It's not by works that I have done. We serve a God who's excellent. We serve a God who has called us to be His servants. We serve a God who wants His work to be a work that attracts people because of its excellence. So that's where we have to start. But we also have to start with our principles. Go back to our principles now. We have to know that systems trump training. So any solution that we work on, we need, as we look at new clinical systems and processes, that we need to be training, we need to be introducing those new ideas in a way that integrates it into their systems, that we're looking at it. We can't each man do what's right in our own eyes and take that to them and suddenly drop it in and have it work. So it's upon us to realize that no amount of training is going to change their system. We have to work within that. We also have to recognize that systems trump programs, that no amount of fix-it programs are going to work. Let me give you an example. Just over a year ago, we had a medical team that was in Malawi. And we had with us 2 masters, nurse practitioners, midwives. And the hospital did a high amount of obstetrics. Well, on the first day there, they discovered that while the hospital had a drug called Cytotec, which is used to induce labor, they had no protocol at all for postpartum hemorrhaging, none whatsoever. And they said, this drug that you have is the drug of standard, is the prescribed drug for postpartum hemorrhaging. And they were all excited. We're just going to take it and we're going to teach them. And fortunately, the physician that was along with us, a member of our board, great internist, a lot of international experience, he said, let's go back to the hotel that night. They got on the internet, looked up the WHO standards, and the next day they were able to go back to the hospital, sit down with the medical director, who was an OBGYN, help her work through the process of what are the standards, what's the expectation. She then worked with the nurses, and they looked at their system. And by the end of the week, they had the understanding and had implemented that. They asked me, I went back into town, bought 2 tackle boxes or toolboxes, plastic toolboxes, and they set that up so that they had like an emergency kit with the instructions in the lid that sat on the unit. So if they had a postpartum hemorrhage, right there, they opened the kit, there was the instructions, they had the drug ready and available for them to use without having to go back and find a doctor and having them tell them what to do. Perfect example of figuring out how to work that into the system. But I tell you, no amount of my buying tackle boxes and shipping those off to hospitals in Africa is going to change that issue. You have to figure out a way to help them change their local system. So what can you do? Translation can only be done through relationship. My encouragement for us to think about is revisit our short-term team philosophy. Meaning, we need to think about, when we do short-term teams, what is it we're trying to accomplish? Read the book When Healthcare Hurts, not When Helping Hurts, When Healthcare Hurts. When Healthcare Hurts is a great book on best practices for short-term medical teams. And the third point would be, when you start working on your medical teams, start with the idea of long-term relationship, not just a one-time trip. Bill Gates said recently, most people overestimate what can be done in 1 year and far underestimate what can be accomplished in 10. What can you and I do? Oh, one last point. Nurses. If you think about the nurses, let me get the numbers here. There are 2.6 million nurses in the United States. And if we use the Gallup poll statistics, let's assume that, based on the rest of the population, 20 to 25% of that 2.6 million would identify themselves as engaged Christians. Now let's assume of that 20 to 25%, roughly 20% take action and get involved and want to see change. That means we got a workforce of about 100,000 nurses available to be able to implement and impact change in the developing world. Our mission partners are facing great change. They are depending on us to help them through this. It's a wave, it's happening to them. If we don't want to let them give up the proclamation of the gospel through medical care. So what I'm asking you to think about is think intentionally about your place in medical missions. You're needed more than ever, but you're needed in a new and different way. You're being called to equip and empower. You're being called to change and create new systems. I would encourage you, go, but no more fish. Thank you.